Attendees are in listen-only mode.
Well, hello and welcome to today's program, the ABCs of MIPS. Our December event, we're talking about planning for the 12 months prior to MIPS landing here in January 2017. I'm Carol Flag with High Tech Answers. Thanks for taking time to join us today. We know you're busy headed into the holidays, and wherever we are, I hope you're safe and warm. Of course, our experts are from SA Ignite. Tom Lee is the founder and CEO of SA Ignite, and he is a leading national expert on MU, the MIPS program, and other various CMS incentive programs. He's been in this space for a number of years. We've known him dating back to HIMSS the last 4 or 5 years. We always interview him, and we're thrilled to have him sort of leading the charge on educating our provider audience on the MIPS program. Joining him, of course, is Beth Hauk. She's also the VP Client Services of SA Ignite. She is a legitimate MU expert, and will answer any questions that you've got if you need to email her directly related to MU, and of course email Tom at SA-Ignite for questions related to MU PQRS, the MIPS program, etc. So we've got a lot to talk about today. So Tom, I'm going to go ahead and give you control. I'm going to go on mute, and then I will see you back on the Q&A.
Sounds great, Carol, and happy holiday to you and to everyone. Looking forward to having a nice discussion here today. So a recap from November's webinar is that we walked through some of these scrubbing activities that can be done for MU and PQRS for the 2015 performance year prior to submitting your data. And we looked at some of the potential benefits in terms of maximizing scores, reimbursement dollars, creating an ever more robust audit trail to help defend against audits, and also identifying certain technical or data issues early in the process and far ahead of the deadline so that you can avoid a last-minute fire drill. So we are busily also updating with the latest webinars, including this one, as soon as possible, onto our website at that link, and you can access that through the resources link on our website, including the presentation as well. So now moving really into today's agenda, by all estimates so far, MIPS is going to start 12.5 months from now. January 2017 is the most likely projected start date for the first performance year of MIPS. And so there's really a question that may be running through a number of your minds is, based on what we already know to be final in MIPS, and not everything is final yet because the actual rulemaking process is going on. However, there are some things that are fairly important that are finalized in the legislation already. And based on those facts that are not going to change with the rulemaking, what is it that we can really do? What activities can we do during what parts of 2016 that can best prepare you for that rollout of MIPS in 2017. So this is really going to explore this topic from a number of angles today. So the first question is really where to focus in preparing for 2017, and it really starts with how the MIPS points are actually going to be allocated among the various categories under MIPS. And it turns out that MIPS actually ramps up over the first several years of the program in terms of how these points are allocated. So most specifically for the 2017 year, that first performance year, there's actually extra emphasis put on the PQRS or value-based modifier quality score. And this is a quality score that many of you have seen on your QR/UR reports out of the value-based modifier program for any of you all that have Part B, Medicare Part B providers that are PQRS eligible. And you can see here that actually between meaningful use and the quality component of PQRS and the value-based modifier score, that's 75% of your MIPS score in the very first year. And another area we're going to talk about today is this clinical practice improvement areas, that although there are a number of activities that qualify for you for points in this category that still have to be defined in the rulemaking, there are already some things that are already in the legislation where you can earn a guaranteed number of points in this area. So those are things that actually have some lead time associated with them and get into. And then really ultimately starting with that 2019 performance year is really where the program ramps up into what many of you all, and we talked about this previously, it's the ultimate distribution of points among these programs all gets to this baseline level, the steady state level. Okay, but the first year you're going to make a lot of progress by focusing largely on things that you're already focused on, but really paying even more attention to them. So we're going to go through a little bit of a calendar in a moment in terms of what to do when throughout the year. But the activities that we're going to talk about can really be categorized into the following areas of things that you can do in 2016 to prepare you for MIPS in 2017. The number one priority is that you'll see in a moment is that there are certain externally imposed deadlines that happen throughout 2016, whether it be from CMS, directly in black and white, whether it be operational deadlines that, based on our experience, you need a certain amount of time to do something in order to be able to meet something further downstream in time for 2017. But meeting those external deadlines that are largely out of your control are probably the most important priority in terms of how you're going to plan out your strategy, your budgeting, your execution, and ultimately your performance targets for 2016, and then leading into 2017, that gives you a great head start. So deadlines is going to be a big focus. The other way to look at what we're going to discuss today is ways that you can optimize the 75% of your first year score in meaningful use PQRS and diabetes modifier. We've certainly discussed these things, these programs in a number of different contexts over the last 6 months in these webinars. However, what we're really going to get into is what are some ways to actually space out these efforts over the next 12 months that match up with deadlines, and they give you a view into the future in terms of where you need to have resources allocated throughout the year, okay, to get good position with MIPS based on what we know about MIPS now. And we will also look at that fourth new category under MIPS, the clinical practice improvement area, that makes up 15% of the score in that first year and subsequent years. There are actually some options you can look at in the year 2016 that could actually lock in a certain number of points for you, in 2017. And really sort of the general consistent theme throughout what we're going to talk about is that you can really look at 2016 in a way as kind of a rehearsal year for MIPS, given that 75% of MIPS really is meaningful use and the quality side of value-based modifier PQRS. And so really consistently looking for opportunities to develop and implement those best practices across these three programs, and also looking at potential ways to really reorganize your teams and your processes within these three programs to prepare for really the merging of everything together underneath MIPS. All right, so we're going to get right into it, and Beth and I are going to do a little bit of a tag team here. We're going to go quarter by quarter. First look at Q1, and then look at Q2 and Q3 together, and then look at Q4. And so I'm going to invite Beth to just walk through in terms of the meaningful use related activities that make up 25 of the 100 points in the first year of MIPS to really take us through the timeline for Q1. Go ahead, Beth.
Sure. Hi, everybody. Thanks for, again, being on this webinar, and happy holidays to all of you. So I'm going to review all of the MU parts of the activities that Tom was talking about. Here in just upcoming, a few weeks away here in the first quarter of 2016, there's a few key deadlines and key activities that we think you need to know about. First off, if you haven't seen it everywhere, the MU attestation site does not open until January 4th. So that's the first key milestone that's going to be happening. An activity that you can work on in anticipation of that, and certainly right when it opens, is to continue to scrub your MU attestation. So what we talked about in the October and November webinars, scrubbing meaning really making sure that you have all of your administrative details tightened up, as well as all of your audit documentation airtight and organized well. The other key deadline that happens in this first quarter is that you are able to apply for the 2016 payment adjustment reconsideration. So this is really your appeal. So if for some reason you failed an audit or your MU attestation in 2014 was rejected in some other way, you do have the ability to appeal that. So you have until February 29th to appeal that and apply for that payment adjustment reconsideration. On the 29th of February, that is right now the published due date for when the Medicare attestations will be due. They're very clear on published, so we anticipate that there's at least somewhat of a possibility that this deadline will move this year, but right now that is the published deadline. That is also the published deadline for some states. So not all states, and it just as any year, it varies very much by state, so check to make sure what your state is saying right now. The state sites are not able to be published until after that January 4th date, so they are required to get approval from CMS that their site is covering all of the elements that it needs to cover, so they're not able to launch until after that at this point too. And then any kind of information about this reconsideration I mentioned was due on the 29th. If there's an opportunity for you to also scrub those Medicaid MU attestations, this is also the time for you to be doing that. And there's a number of things that you can be doing to scrub those, not the least of which is really to double and triple check those eligibility figures. We know that because you're able to choose a number of different time frames by which to qualify to show your eligibility window, including the calendar year prior to your attestation date, that's a moving target, which means that all the way up until the time that you decide to attest, you have some different time frames that you can determine for when you can do your attestation. So those are all the things that we would have you focus on in the first quarter as it relates to MU.
Great, thanks, Beth. So moving on to the 50 points that the PQRS value-based modifier quality score can really drive. And we've talked a lot about this, again, in our previous webinars, and so you can certainly go back there for more details. But the very first order of business getting into Q1 is to select your final PQRS measures for submission purposes that are tied to any one of these different deadlines, depending on if you're using the EHR direct method, the GPro web interface method, or using one of the registry methods. And this is really about trying to optimize for your score. We've gone through that a number of times again, but the one key distinction to keep in mind is that the measures that you may have monitored throughout 2015, as far as aligning your providers and trying to drive towards this organization, leave open the possibility that those measures that you thought at the beginning of last year would be the ones that you want to submit are actually potentially not the ones that you ultimately submit, because the ones you ultimately submit, for many reasons, may be the ones that you want to have that will deliver the maximum reimbursement and or the maximum public reputation as far as these measures being publicly reported. So really that dividing line between what you monitored and continue to want to monitor may not always be the same as the measures you actually want to submit for each of your providers or each of your tax IDs. And then obviously doing the submission, and we'll kind of come back to this later on as we get into Q4 of next year in terms of how you then prepare for the following year, so we'll cover that then. And then during this time frame is also really completing your CAP surveys. For those of you who are GPro organizations that have at least 100 providers, it's really in this time frame when your CAPS vendor needs to deliver to you and actually out to your patients and then really collect the results for your CAPS or PQRS survey. So make sure that those timelines are adhered to, because it's important for CMS to get those measure results in on time too. That's the patient satisfaction surveys. All right, so this final track is kind of interesting, and it's relatively new in terms of our discussions the last couple months. Is this new category, the clinical practice improvement area, which makes it 15 points. And what I'm going to do when I come back to this track is really talk about two different types of activities. One is related to the potential that you either apply for or renew your status as a shared savings or a next-gen ACO. Okay, next-gen is basically more of an experimental program out of CMS where there are probably 20 to 30 organizations that will be chosen by CMS about half of them have already been chosen to really test new models of ACO. And by really being either one of these types of ACOs, for the most part, your providers will generally be exempt from MIPS. And for any providers who may not have enough billings through your ACO that will then fall back into MIPS, for those providers that still fall into MIPS, even though they're in ACO, they'll be guaranteed at least 7.5 out of 15 points just by virtue of their membership in your ACO. Okay, so this is really is quite impactful in terms of the MIPS impacts, is whether or not you want to be an ACO or you want to remain an ACO. Now, the other track that we also know that's certain from the legislation is that if you are a patient-centered medical home certified by NCQA, and there's potentially some other PCMH models that may come out through the rulemaking that may also qualify, but right now NCQA one is fairly certain, that if you are able to be PCMH certified throughout the entire 2017 performance year, then you'll automatically get 15 points in this category regardless of anything else that you may or may not do. And so for organizations that are thinking about, well, should I let my PCMH certification lapse or should I try to go for certification for the first time, this is a very key thing to consider. And really, in this first quarter, you're going to start seeing information about this program start to come out, particularly the next-gen ACO program for that next wave of ACO implementation that would start 2017. That information is actually available at the end of the quarter, around March, to come from CMS. So something to keep track of during that quarter. Okay. So now we're going to look at Q2 and Q3, really that middle part of the year together. Beth, go ahead and talk through the MU points, and I'll pick up the baton after you're done.
Sure. So this is an important point in the program to evaluate eligibility of a whole set of providers that have some unique requirements as it relates to eligibility. So one group of those providers are the hospital-based physicians. So the CMS calculates the hospital-based percentage, which is available as soon as you register a provider on the CMS site on a rolling basis. So somebody's hospital-based eligibility can change. We recommend that you go ahead and try to register people for the program around this time, say in the second quarter of the year, so that you can find out somebody's hospital-based status right at that time, so that you're not getting any surprises of people that are deemed to be eligible who you expected to be ineligible and weren't necessarily monitoring their information. The other key group is the anesthesiologists, pathologists, and radiologists who are automatically exempt from the program if they, in PACOs, have registered themselves as one of those specialties in the 6 months prior to the reporting year for which they're being evaluated. So you really need to do that prior to June 30th so that those go into that exception category. And then the last group is optometrists are eligible to receive incentive dollars under the Medicaid program for certain states. So it's important to check with your state to see whether or not this is potentially a group of providers for which you can get incentive dollars that you didn't realize you could get. Obviously key to kind of do that stuff earlier in the year, because for those people that will have a full reporting period, you're going to want to know that information early. Any of the hardship exemptions are going to be due by July 1st. So you're going to have to, again, for any 2017 exceptions that you're going to file, you do have to file that paperwork in by July 1st. And then this is potentially late, potentially early, depending on your organization and the, I guess, scope involved in upgrading to it. But there is the option in 2017 for you to be operating on a 2015 certified system and to basically do a trial run of MU Stage 3 at that time. So at this point, you need to know whether or not that's a direction that your organization is going. It is not required to, it is completely optional, but if you feel that it could help your organization in particular get a leg up on being ready when stage 3 comes to be in 2018, and therefore make you more able to address the MIPS program, then we definitely recommend that this be a conscious decision by the organization as well at this point.
Great, thanks, Beth. You know, one thing that I neglected to put on the slide, but that is also a key milestone, is it's really around this period of probably July to August or so, when, and possibly earlier, is when the draft MIPS rule for 2017 will be released. And so this period of time is going to be a lot of trying to digest and triangulate where MIPS is ultimately going to end up. Our company will obviously be doing a lot of work in that area, and it's going to kind of underlie really a lot of the things that you're going to see on the slide, as well as the subsequent slide. So one thing that for the quality side that is also a must-do is to really look at this decision about whether or not you want to file PQRS as a GPRO using the group mechanism, and be able to declare that to CMS by the June 30th deadline.
Tom, are you there? Tom?
As 100 providers or more, where you're required to carry out CAPS. And the reason why you want to really think about that ahead of time, and that may involve looking at your historical CAPS scores, you know, talking to folks in your team that are responsible for patient satisfaction, is because when you go to declare your GPRO method, you do need to choose whether or not you want your CAPS scores to be included in your score or not. And that can obviously depend on where you think your CAPS scores are going to be, and whether your organization is ready for those scores to really count towards your QR/UR quality scores and to drive your reimbursement for value-based modifier. Okay. All right, and then in this third track, this is really where a lot of the deadlines around ACO really hit. And again, ACO is a way for you to be exempt from MIPS, but even for providers who ultimately still fall into MIPS, you're going to get at least 7.5 points for those providers that still fall into MIPS under an ACO. And so the deadlines to keep in mind here, the rough timelines, is that the latest information for the original shared savings MSSP ACO program will be posted around April. And that will be really kick off some time of really looking at the latest information and folding that into your decision about whether you want to apply to be an ACO or whether or not you want to renew. If you do want to do either of those actions as far as applying or renewing, then the letter of intent to send to CMS is due by May 1st. And really beyond there's only about 3 or 4 months after that when you actually have to submit the entire application. But May 1st you have to hit first in order to even be considered to be an ACO. And I'm sorry, actually it was May 29th. I'm sorry, May 29th for the notice of intent for the shared savings ACO. And similarly for that next gen ACO program, you have a letter of intent that's due around that same period in May. And so these are really trigger points to keep track of for ACO consideration, either new ACO or renewal of your ACO contract with CMS. And going further is for those of you who do go down the PCMH track to really try to get the certification for PCMH or renew it. Really, what we have really seen is that it can take easily 6 to 9 months of pure work to really get all of the information together for PCMH, as well as to make workflow changes so that you can get your data submission together for PCMH to put into your application. And so if you really work backwards from the time in which you'd have to have PCMH done in order for it to apply for all of 2017, you're probably looking at the latest getting your PCMH application to NCQA by August. And so you really have a lot of work leading up to that throughout the bulk of 2016 if that's the path that you want to take. Okay, so that's Q2 and Q3. And actually the final thing is really across all these areas is that budgeting is often happening in your organizations in that Q3 timeframe, budgeting for the following year. Many of you have seen and we've walked through our MIPS financial calculator, which you can get for free from our website. That's been very useful in the C-suite to understand what is at risk for the organization, both on the upside as well as the downside, that can help to motivate a budgeting discussion. And I encourage you all to look at that and let us know if you have questions about that. But remember that the budgeting for MIPS, particularly in light of knowing what the draft rule for MIPS is going to look like at that time, it could be quite different from the way in which you've budgeted for MU and PTRS and value-based modifiers separately in the past. And knowing that they're all going to be really rolling up in the same score could affect how you're going to want to budget for and allocate resources. And this is the time of the year to really do that within most of your organizations. All right, so Beth, let's go ahead and finish up with Q4.
Sure. So first key milestone that's on there is that anybody that is a first-time attester in 2016, the attestation, similar to what we've experienced most years, if that person's attestation is due by October 1st in order to avoid penalties for that 2016 payment year. So you want to make sure you get that in. If you attest them by the end of the year, they will simply be avoiding penalties in 2018, not in 2017. As I pointed out on the previous slide, kind of that decision to determine whether or not you're going to implement that optional 2014 15 certification in there would be happening in the fall and in the last quarter of the year. And then you'll also see that you're going to be spending a tremendous amount of time. This is going to feel very similar to 2013 when we had lots of people in a full year attestation year. So your ability to have that rolling attestation and have people meeting 90 days at different times is of course going to go away, and you will have most of your providers in all likelihood in a full payment year. So the last 90-day period for first-time attesters will be in 12/31, but then the last, obviously, the full year will end 12/31. So you're gonna really be spending a lot of time in that last quarter trying to get people that have perhaps had meaningful use on the back burner for a bit, trying to kind of double time it up as you try to get them to make up ground for what happened earlier in the year.
Great, thanks, Beth. And what we're also seeing in the market is that there's been a resurgence of interest in Medicaid meaningful use as the timeline for Medicaid meaningful use incentives really starts to wind down over the next 5-6 years. Another thing that maybe is also on top of many of your minds for those of you who are dealing with a lot of Medicaid providers. Certainly encourage you to reach out to Beth directly. In particular, she's got a lot of pretty recent experiences around that, and we'd love to hear from you and learn from you about that. All right, so in terms of the quality side, in October is when you should have your 2015 QRUR in hand from CMS. So that's really a good opportunity to really analyze that as we have in some of our past webinars to really understand not just the final score for quality and cost, but to really dig into some of those other things we cover, such as in your supplemental exhibits, where you can see, for example, where are your patients going outside of your tax ID to go to other places for care. There's a lot of very rich information there, and that's a great time to actually really get into that information perhaps more deeply than you've had a chance to for in this past year, because a lot of that data could be very useful as you think about how you're going to plan for MIPS in the following year. This is also a good time in which to really, for those of you who are required to do CAPS as G-Pros, is probably the best time to really go and select your vendor, because the CAPS vendors have traditionally been able to really start getting surveys out to your patients in November. And so if you want to get a head start on that process, this is a great time to do that. And also in terms of selecting other vendors that you may want to assist you with PQRS, for example, whether it's a registry company or otherwise, is another great time to really make that decision before and really kind of get on the implementation queues of these vendors ahead of time before the submission season comes. And then really for the bulk of the rest of the year here, it's really selecting, getting some sense of, okay, when 2017 starts, what are the measures that you want to really monitor and against, and to really drive your organization to improve upon. Ideal time to do that, and I just mentioned the CAPS part as well in terms of starting that process. And then in this clinical practice improvement area, really a lot of the PCMH time frames fall within this area. So if you were to put in your application in August at the latest, then you would receive a decision on PCMH from NCQA around October. And then if you actually fail that decision, you have an opportunity to resubmit, which if you were to do that in October as well, you would have a second bite at that apple where the final decision would still come back in time in December for you to have a fully valid PCMH certification for all of 2017 and thereby be able to get the full 15 points, okay, or the same for renewal. So that's really our summary of these quarters sort of broken out, kind of a different way of looking at a lot of the information at a higher level that we've talked about the last couple months. We'd like to point you at some other resources here. We actually just launched this on our website, is that we have decided that throughout 2016, we are going to be releasing MIPS tools and information targeted throughout the year. The idea being right information at the right time, not too soon, not too late. And if you are interested in receiving information through email about that as we come up with those tools and educational pieces, invite you to go to our homepage where you'll see a little pop-up window that appears in your lower right-hand corner. If it doesn't pop up for whatever reason, you can also send an email to info@SAIgnite. I'd love to get you on a list and engage with you and allow you to benefit from those tools and information as we develop and release them throughout the year. Also, as usual, resources that you can look at, including this set of webinars. And then finally, we have done quite a bit of work out of the MIPS LinkedIn group that has helped us inform some of the comments that have been submitted to CMS. And you'll see that dialogue about that on that LinkedIn group, so feel free to take a look at that and join, and we'd be happy to have you there too. Okay. So Carol, I think we're ready to get to questions.
Yep, you got it. Let me just go back a slide. Let's see here, the Q&A. I just want to remind folks that Tom's email is tom@SAIgnite, and Beth's email is beth@SAIgnite. So we're going to go ahead and start with some of the questions that came through the registration process. We've got a ton of questions sitting in the chat queue as well. If we don't get to your question, again, please reach out to Andrew or Beth to get back to you, and they'll get back to you. First and foremost, and in no particular order, just the order in which the registrants sent their questions in. ACO reports G-Pro for all participant TINs. The specialists are questioning how they are measured since ACO metrics are different than PCP-centric.
Great question. PCP-centric really refers to the bulk of the ACO measures being primary care-centric. It's a common question from specialists, and really the answer to that really resides in how the ACO quality reporting process actually works. It's basically exactly similar to how the G-Pro web interface process works for those that are not in an ACO but choose that mechanism for reporting. And what happens is that CMS will select for you 248 patients to report on for each measure, and you'll be presented those patients in a identifiable way on the web interface tool provided by CMS. And so really the impact of specialists is that it's it's really at the discretion of CMS as to which patients they pick. And if it happens to be that some of those patients are very heavy on receiving specialist services from your collection of ACO TINs, then that performance will naturally be expressed through whatever measures in the set of, I believe it's 17 right now, that are relevant to this performance year. So really it's an indirect, it's not a direct correlation with specialty, with the kind of the nature of that question there. It's really, with the ACO program, there is no other option for reporting quality. And it really is at CMS's discretion to see what patients they actually come up with. Yeah, so, Carol, I think we...
Okie dokie. Do CQM measures for meaningful use have to be aligned or the same as PQRS measures? That's a good question.
Sure. I'll give a quick answer to that, and Beth may also add some commentary just about CQMs in general for MU. So the answer is that if you attest your CQMs for MU using MU attestation, there is no requirement that you pick the same CQMs for filing PQRS electronically through using what's called a QRDA file that your EHR vendor can tell you more about. However, realize that if you do report PQRS electronically and you don't attest your CQMs through MU, that the PQRS CQM electronic filing can also count towards your MU CQMs, but you have to indicate as such within your attestation. So, Ben, I don't know if there's anything else you want to add about CQMs to MU beyond what I just said there.
Just a couple small things. We do hear a lot with clients that while just what Tom said is exactly true, that they feel that messaging to physicians is quite a bit more consistent if they can just pick the same ones. So we see that happening just so that nobody has a copy of their final attestation summary and they say, well, why the heck did you pick this screening when that's not even relevant to my patients? So we do hear that. And then I think that just the second thing to remind everybody is that if you do use the EHR direct method and get the double counted for the PQRS and the meaningful use program, that submission happens for a full year's worth of the CQM data versus a attestation that for a 90-day period will only require you to attest for the CQM data for that 90-day period. We hear some organizations that are attesting for PQRS with EHR Direct where it would count twice, that they go ahead and just also attest via attestation simply because of the timeline difference, and they want to be able to get that information to CMS faster and not have to wait for that full year's worth of CQM data to be available.
If an EP elects to use PQRS submissions via EHR and the submission of PQRS is unsuccessful, would that lead to failing MU as well?
Yeah, that's a related question. And the answer is there's only that cross that the failure of MU as a result of failing your electronic PQRS submission would only occur if in your MU attestation you indicated that for the MU CQM requirement that you are relying on the electronic submission through PQRS, or otherwise known as EHR Direct. So if, again, extending off what Beth says, if during your MU attestation you decided to still attest your CQMs for MU through the MU attestation process, then your PQRS electronic submission failure would not count against you for MU, but you would still count as a failure for PQRS.
I've got a lot of people chatting in asking about is there going to be recording in a slide deck for today's webinar. Just look in your inbox tomorrow. I usually send it out within 24 hours. It'll be a YouTube video of the presentation as well as the slide deck. So what changes may occur with the incentive/penalty structure as MU and PQRS are rolled up into MIPS?
Great question. This is a great tag team question for Beth and myself. I'm going to say, I appreciate. We definitely appreciate the questioner there for giving that opportunity. So from the MIPS side, MIPS does not impact MU incentives. Okay, MIPS only actually consolidates the MU Medicare penalty into the MIPS penalty, which is a global penalty that also subsumes the PQRS and database modifier penalties as well. So really, for MU incentives, it's business as usual for both Medicare and Medicaid. Now, obviously, Medicaid is of growing importance relative to Medicare as the Medicare incentives start to die down to zero. Really that's kind of the that's the way in which, from a MIPS standpoint, that those things happen. Beth, you have anything to add to that?
Yeah, just one thing. It's a good opportunity for me to remind everybody. In 2016 is the last year that you can get Medicare incentives. So that's going to be your last year that you can get incentives. The penalty phase, when that begins in 2017, that will be fully subsumed into MIPS. So you're not going to get a separate MU penalty. It'll be fully incorporated into the MIPS penalty. But as it relates to Medicaid eligible, 2016, you need to start the program by 2016, and then in order to get the maximum payment of the $63,250, you're going to need to meet meaningful use every year up through 2021. So 2016 is a pretty key year as it relates to incentive dollars.
And this next question, I shouldn't assume, but I'm thinking the asker may mean PQRS and MU. One last question sort of in the area. We keep both programs separate at my organization. What's the best step to start combining the two programs? Not sure what two programs are talking about. Yeah.
That's an awesome one. I will give a high-level answer, and Beth has seen a lot of things in the field related to this. And the question really is that the organizational question, which we also touched on in our presentation today, is given that MU has traditionally started out as an IT project under the CIO, whereas PQRS and diabetes modifier have traditionally been a quality project starting under the Chief Quality Officer or VP of Quality or VP of Physicians. And where do the two meet? How do you really look at it as one single MIPS program that now is going to be forced together by MIPS? So what I've seen, I'll just share one example, and I'll hand it off to Beth to kind of talk about this and some of the real mechanics of what we've seen out there, what works and maybe what doesn't work. At a high level, we have seen more and more C-suite executives start to collaborate on this, specifically the CIO and the CQO. Often, when the MIPS financial impacts are known by the CFO or the COO or the CEO, and them actually forcing the discussion, or at least making sure that the discussion happens in terms of these programs being managed or starting to move towards being managed together at the senior level. And that certainly filters down to other parts of the organization. And I invite Beth to maybe comment a bit on that in terms of, on a day-to-day operational level, what are some things around this MU and PQRS management issue that she might be seeing out there right now?
Sure. There is no magic bullet answer because every organization is different in terms of size and in terms of resources. We are seeing a ton of this going on right now. In particular, the PQRS person that used to only run PQRS has suddenly been told, hey, you also get MU, or vice versa. So you're seeing resources that previously had a single program being asked to be stretched to cover more scope, which means the amount of regulatory knowledge that it has to be in a small group of people tends to grow. What I've seen as a result of that is there's been quite a bit of movement to offload much of the administrative tasks associated with the programs. In particular, I would say some of the eligibility pieces, some of the finance and tracking, even some of the attestation and proxy designated official work that needs to be done, honestly, for both programs. I've seen a lot of that getting peeled off of the typical meaningful use manager or PQRS manager and being moved into more of a finance role, so that you're gaining capacity in the quality areas so that the people that are running those programs can spend quite a bit more time educating the analysts or IT trainers or practice managers, again, depending on the organization, how to change their workflows to meet both programs. We definitely recommend, and I definitely see best practice out there, is to merge them, because it starts to get very confusing to the people that need to implement these programs, that they're so similar yet not the same. And so when they're at least under a single roof, under a single manager, that starts to simplify things quite a bit, and that person can then serve as the clearinghouse for what's the same and what's different, and be able to communicate that more simply down to the people that are working more closely with the physicians. So this could, I could do an entire webinar just on this.
Just on this.
I hope,
Hey, I think
yeah.
That's a good point.
So
we'll plan for it.
I hope that explains it. I hope that explains it well enough in the answer to the question.
Yeah, it does. So one last question on PQRS. Regarding PQRS, is CMS planning on doing away with the claims process? And if so, when and what would
Great
be
question.
the alternative to that?
Right. So by way of background, the claims process that's being mentioned here is the really kind of legacy, I would say, way of submitting for PQRS, whereby you use things such as G codes in your claims submission process to mark certain claims as related to certain quality measures, and then CMS does the calculation for you. It's hard to say if CMS has a hard date in mind for completely phasing out that program, but it has fallen out of favor as CMS has learned that more than 30% of the claims-based quality measures are highly inaccurate. And so as a result, if you look at the ways in which the other methods have been opened up, probably EHR Direct most recently being the most prominent one, and certainly over the years registry, that it's clear that CMS is really trying to lower the barriers of those other methods relative to the claims-based methods, such that we've been seeing a huge movement towards non-claims-based methods over the last 18, 24 months in particular. So I think given that, if you really are concerned about trying to get advice, expertise around PQRS reporting, increasingly you'll find a much greater weight of that expertise and vendors and options in the non-claims-based methods, such as a registry, EHR Direct, QCDR is another one that is emerging. So that's something to kind of factor into your thinking. But no, CMS has not publicly announced any exact end date, for the claims-based process that at least I'm aware of.
Sort of sticking with this EHR line, what methods of submission are available for EHR adopters who have not been able to use QRDA data files for electronic reporting?
Mm-hmm. Yeah, another great PQRS question. The QRDA file is the standard XML-based file used to submit CQMs for EHR Direct for PQRS. And that can be done either for a GPro, for group reporting, or for individual providers. The bottom line is, just by definition, that is the only way to do EHR Direct reporting, is using a QRDA file. Now, your vendor should have been certified as a full or complete EHR to have the ability to export that file. But it's at the vendor's discretion as to whether or not they want to charge you for that file or charge you for the ability to do EHR Direct. They have full discretion. Your vendor has full discretion to determine that. That being said, the number of the major vendors are providing that file at no additional cost above their usual support packages that you'd probably be buying anyway. Really, the only other, the other ways in which an EHR comes into play when you don't have access to a QRDA file, in particular if you don't want to pay for one, and if your vendor is charging for one, is that you really then are only using your EHR to support those other reporting methods. But and that may be registry, but then that's basically running queries against your EHR to give patient-level data elements to your registry vendor. If it's a web interface method, it's kind of the same thing, but you're doing it in-house for the most part. There are some third-party vendors that give you some assistance with that. But if it's not using the QRDA file, it's really just using the EHR as a data repository where then you use it as the way to kind of look up information, for those other methods. But that's often not an automated process. That's often pretty fairly labor intensive, either by an analyst or by actual clinical folks combing through patient records in the EHR to try to meet the data element needs of a variety of different reporting methods.
How will our MIPS score be calculated if we don't qualify for MU?
So given that MU can range from 0 to 25 points, particularly in that first MIPS performance year, the final rule for MIPS is going to determine whether or not someone who, let's say, only conforms to half the MU measures, whether or not MU is going to be an all or nothing program still. So it's conceivable that if a provider today is only meeting less than the required number of MU measures and thereby now being deemed completely non-compliant under MU, that when MIPS rolls out, it is possible that that provider could still get some of the 25 points, okay, for partial compliance. A number of organizations like Chime has submitted comments to support that. And I think there could be some momentum building behind that, for the final rule for MIPS. So we're not going to know for sure until the July draft rule comes out, and then we'll hopefully be able to answer that question a little bit better, once we get to the July-August timeframe.
Right, and that's when you anticipate the final rule coming out.
The draft rule.
The draft
rule. The final rule would still be in that probably that October to November timeframe for the final rule.
Because they'll have a comment period, right? Mm-hmm.
Yes.
Right. Does our PQRS VBM score go down if our EHR does not have 9 measures we can report on? We can only report on 8.
Mm-hmm.
Does that put us at risk for losing the incentive?
This is a great question, and the subject of many a CMS support desk call. So the really interesting thing with EHR Direct is that what the minimum reporting requirement currently says is that you have to pick 9 measures across 3 quality domains, unless you are a G-Pro that has submitted your CAP scores, then you only have to report 6 measures across 2 domains. Okay, so that's something to keep in mind for those of you that have EHRs that only support 9 C2Ms, that if you are a G-Pro, you have the option to, and it's required if you're 100 EPs or more, but to do your CAP survey for patient satisfaction, and that reduces it down to only 6 measures across 2 domains instead of 9 across 3. Okay, that's kind of point number 1. Mm-hmm. Point number 2 is that if you are not in that situation, that you're looking at, by the letter of the law, having to report 9 across 3, the EHR Direct rule does give you an out. And we've actually seen this be successfully accepted by CMS as a result of last year's submissions that we saw the QRURs and we saw everything that came out in the last couple months. And that is that in principle, if you have less than 9 measures, you're just required to report all the measures for which you have Medicare patient data for. Okay, and you can even, for workflow reasons or for technical limitations, your certified EHR only has data for 2 measures. Then for EHR Direct, you can just report 2 measures, and as long as you have at least one Medicare patient's data among those 2 measures, then you're good. You're good as far as being able to avoid the automatic negative adjustment. Now, whether or not you're good as far as your quality score for value-based modifier all depends on what your measure values are relative to benchmarks and all the way that the algorithm, works and cranks out, and a number of you know that that's something that our company can help predict what predict what your score is going to be. That will all depend on what your data is in terms of what your value-based modifier quality score will be, but you will at least avoid the negative adjustment just by reporting all the measures that you have, even though you may have less than 9. And this is not true for a variety of the other reporting methods. You don't have this out for many of the other methods where you really still have to stick with 9 or it's very onerous to try to report less. You have to go through alternate logic to determine if you're able to do that, whereas EHR Direct, it's all very, very clear and simple.
You talked a little bit about hardship on one of the slides. What is the earliest we can apply for a hardship exemption for the 2015 MU attestation? I realize the deadline is 7/1, but could we apply as early as the February-March window?
You can apply for your hardship exemptions earlier. for sure. There's nothing that prevents that. So in particular, there's a number of different hardship reasons, and I'm happy to send over the link if anybody wants to send me a note. There's a number of different hardship exemption reasons, and so some of those are ones that you're going to know quite a bit earlier than not anyway. So certainly those are ones that you can submit sooner.
Okay, great. Where can I find a list of all approved APMs?
Yeah, so APMs is the alternative payment models that were part of the macro legislation that was part of, that really gave birth to MIPS. And alternative payment model, the one example we've talked through throughout this presentation is the ACO, a shared savings ACO, or a next-gen ACO are all qualifying as alternative payment model. Now, probably the most comprehensive list you can get of APMs that fit into those two categories is on the CMS website, and it's easy to Google this, is, MSSPACO, CMS. You can Google those three words together, and what you'll get to is that when you go to that ACO page on the CMS website, there is actually a link to a list of all of the ACOs by name in the entire country. So that'd be a good place to look for, peers or others in your region that you can share some thoughts, ideas, and questions with. I encourage you to go there for that.
Can you summarize what being part of a MIPS ACO gets you out of? Reporting? Yeah.
Yeah. So what as we mentioned before, is that if you are a shared savings ACO, for example, which then is an example of this APM, alternative payment model, then what the macro legislation says is that all of your providers that are billing above a minimum amount or are seeing a minimum above a minimum amount of patients for which they're billing, where you have enough Part B visits or Part B patient revenue that is being billed through the ACO as opposed to other Part B fee-for-service. If that percentage of ACO billings is high enough for a given provider, then that provider under the ACO would be exempt from MIPS. But really, for many ACOs that have hundreds or even thousands of Part B providers, there's always going to be a subset of those ACO providers that are actually not billing enough Part B payments through the ACO and are still doing a lot of fee-for-service Part B. Okay, so a classic example is you could have specialists that they are seeing, they're still deemed to be part of the ACO because they fall under the TIN of the ACO, and they may have some billings that are through the ACO mechanism, but they have too many. They may have. I should be very careful what I'm saying. That specialist may be billing Part B fee for service through a different TIN, okay, that different tax ID, where that other tax ID is not within the ACO. Okay, so it could be a specialist that is, seeing patients that are within the attribution set of the ACO, but are seeing many more patients that are being attributed to a TIN that is not within the ACO. Okay, and that specialist could thereby technically be a member of the ACO, but not have enough billings that are going through the ACO TINs. And that provider would nevertheless, even though they're in the ACO, they would still be subject to MIPS. Okay, so kind of a long-winded answer. Frankly, the rulemaking is now deciding what that low volume threshold is going to be, for 2017. So again, we're going to know a lot more once July comes around in terms of the very specifics about if you do a population analysis of your ACO providers, it'll be very important to figure out which ones are still falling into MIPS. Okay, and that's something we're actually doing for a number of our clients is that type of analysis, because when you stack up ACO versus MIPS, from 2017, you're either one or the other, and some providers are in both. It's a very interesting strategic decision that we're doing a lot of work on right now, but and we're learning a lot too, frankly. But it's going to become more and more important because 2017, that whole world of Part B splits in half. You're either in ACO or you're in MIPS, or some of you are in both of them.
So we get a lot of questions pouring in, and we unfortunately have run out of time. I just want to remind our audience, if we didn't get to your question, and there are many that we did not, please email Tom at saignite and Beth at SA Ignite, and I'm sure they will respond. And we'll, of course, be back again in January as we continue looking at the financial impact of MIPS and all of these various incentive programs. Beth, Tom, thank you so much for your time, and the last show of 2015, and we'll see you next year, as they say.
Thanks, Carol.
Thank you, Carol.
Thanks. Everybody have a great holiday.
Bye-bye.
Happy holiday. Thank you.